This is Belinda. Belinda is 30 years old. She's also, this is her first pregnancy. Everything has been absolutely normal, uneventful during pregnancy. She presented in labor at 38 weeks. Is established label, intact membrane. At that time, it was noted that she has some vesicular genital lesions, which clinically look very much like genital herpes, and she has no history of previous similar lesions. So the next speaker is Dr. Vineesh Bhatia. We are very fortunate at Women and Children Hospital to have Vineesh as a specialist neonatologist. He is heavily involved in research and teaching of medical students and trainees and fellows. And in the other hospital, you may have seen Vineesh sometimes. He comes for the neonatal retrieval. So I'm just passing on to Vineesh.
Thanks, Morgan. Good evening, everyone. So before I go on to the case, I'm just going to discuss a little bit about herpes simplex virus infection in pregnancy and then how it manifests as neonatal disease. And we'll come back to this case after that. So looking at herpes simplex virus, there are two types of HSV. That's type 1 and type 2. They are members of the herpes viridae family. Infection occurs by inoculation through oral, genital, or conjunctival mucosa or any skin breaks. Once the infection takes place, it goes through the sensory nerves and it resides in the dorsal root ganglia, and it remains there lifelong as a latent infection. It is often reactivated, and when it is reactivated, it can either be asymptomatic, it can be there be shedding in the saliva or the secretions, and when it is symptomatic, it usually results in skin or mucous membrane lesions, but can also affect multi-organs. It can present as various clinical syndromes. As you can see, majority of them are actually skin and mucocutaneous lesions. You can have gingival stomatitis, you can have genital lesions, you can have keratoconjunctivitis, and when it is severe, it can be vision threatening as well. It can cause severe CNS disease, so it can cause meningoencephalitis in adults, in newborns, and it can also present as disseminated disease, which carries a very high mortality and morbidity in newborn babies if it is not treated early enough. So even though the incidence is not that large, but it is still an important disease to be aware of, especially in the neonatal period. Now, if you look at neonatal herpes virus infection, type 2 causes 75% of cases and 25% of cases are by type 1. The incidence varies in different populations. It can be from 1 in 3,000 to up to 1 in 10,000 live births. And as I said before, it can cause serious morbidity and mortality and can leave permanent sequelae in survivors. What factors influence transmission to the newborns? One of the main factors which influences transmission is whether the mother has a primary infection or it is a recurrent infection. I'll come to that in a minute in my next slide. The second thing is whether mother has HSV antibodies in her serum. Because if she has antibodies in the serum, then that's protective for the baby. The third thing is the mode of delivery. We know that cesarean sections are protective, especially when the woman presents with primary lesion at the time of delivery. And the duration of rupture membranes is important as well, because longer the ruptured membranes will be, the longer the baby is likely to be exposed to the secretions and to the virus. If you look at classification of maternal genital herpes and what the transmission risk is, it can basically be divided into newly acquired and recurrent infections. And newly acquired, you have first episode primary infection. What that means is that the mother is negative for HSV1 and HSV2 antibodies, and she presents with genital lesions. The risk of transmission to the newborn is highest in this group. It's almost 60% transmission risk to the newborn in this group. And the second group is a first episode non-primary infection. What that means is that mother might have antibodies to HS1, but she presents with genital lesions, and if you do a PCR on that, the genital lesions are actually HSV2. So the antibodies she has is different from the HSV type she has in the fresh genital lesions. So the risk here is a little bit less. It is still around less than equal to 30%, probably because the HSV1 and 2 antibodies cross-react with each other and provide some protection. And the third group is a woman who presents with recurrent infection. So what it means is that she has pre-existing antibodies to the HSV type she has when the lesions are present. And in this group, there is the least risk of infection, which is less than 2%. So if you look at neonatal herpes simplex virus infection, the maximum acquisition or the most common acquisition is intrapartum. So 85% of cases will be due to intrapartum transmission of infection to the newborn. And most cases are acquired from newly acquired asymptomatic cases. So there are a couple of misperceptions we have about herpes simplex disease. And one of it is that, if you don't have genital lesions, it's unlikely that baby will have disease. Well, that's not true, because majority of the time, mothers would be asymptomatic. They would still be shedding the virus at the time of delivery, and you're not going to get a history of herpes lesions in the mother or past history of herpes in the mother. That's why all newborns are potentially at risk. So if babies have symptoms, you need to think about herpes. Coming back to the case, so Belinda, obviously we remembering from the case, she presented at 38 weeks. She was a primary gravida, and she presented in labor at 38 weeks and has been clinically identified to have genital herpes lesion. So what do we think she has? There was no previous history of herpes infection. So she has a primary infection or a recurrent infection? It's not a tricky question. Primary infection? Yeah. I think it's right, but Celia didn't put her hand up, so I'm a bit worried. But look, means we have to assume that she has a primary infection with that history. But it is still possible she might have had an asymptomatic infection before and might have seroconverted, but we don't know that. And given that she's presented in labor, you're not going to have time to get serology back. So for all practical purposes, we would have to treat her as if she's got a primary infection. And what does that mean for the baby? So the baby is at quite a high risk of transmission if she's got genital lesions, which are due to primary herpes at the time of delivery. So I guess the next question is what we can do to try and minimize this risk to the baby. So in this scenario, we would be recommending a cesarean section because that's thought to decrease the risk of transmission. Particularly after rupture of membranes, you need to try and do it as soon as possible, particularly within 4 hours after she's ruptured membranes. So if she would have presented earlier with active lesions and she went into labor, we would need to tell her to come in quickly so that she can have a cesarean section done within that 4 hours time. She would need to be treated with acyclovir. If you can't do a cesarean section for some reason, we would suggest she have IV acyclovir treatment intrapartum. Okay, so I'm talking a little bit about maternal management here, even though we've got sort of 4 or 5 respected obstetricians here. So I'm sorry about that, but I think if there is anything, I'm sure they'll bring it up. So what about management of the newborn? So, for management of a symptomatic newborn, it's quite clear that you do a full evaluation and you do treatment with acyclovir. But what when the newborn is asymptomatic, but there is a higher risk of infection, as is the case with Belinda? So in her case, we would still be doing a complete evaluation for the newborn and would be treating with acyclovir because there is such a high risk of transmission to the newborn. Such a baby is best to be born at least a level 5 facility where you have where the newborn can be supported if the disease is severe. What would investigations entail? So it's a complete examination of the baby. We would do a urine, blood, and as well as a CSF PCR. We would do a CBP and coags because babies with neonatal herpes can have thrombocytopenia, they can have severe coagulopathy, and we would do a LFT as well because they can get liver dysfunction and acute liver failure as well. We would do a CSF microscopy, culture, and biochemistry, and commence the baby on IV acyclovir. After we've done that, obviously you need to watch the baby for any clinical signs of herpes disease. Plus we would do swabs at 24 hours from eye, throat, umbilicus, and rectum. We get asked this question quite a lot of times, that why do a swab at 24 hours? Why don't you do it at delivery? The reason for that is that there is some evidence to suggest that if you do a swab at 24 hours, it is more likely to represent colonization on the baby rather than just contamination from the birth canal if you do it soon after delivery. So that is the reason it is done at 24 hours and not just at the time of birth. So that's Belinda. What about if you have another lady who has a first episode, primary or non-primary infection in the first or second trimester? So whenever a lady presents in the first or second trimester, we still treat them with oral acyclovir or valcyclovir. I've mostly seen them being treated with acyclovir. Plus, the recommendation is to start them on suppressive therapy after 36 weeks till the time of delivery. You can check for seroconversion. Most of these cases, we would still anticipate vaginal delivery as long as it's been at least 6 to 8 weeks since the lady had these lesions. The reason being that it takes around 4 to 12 weeks for seroconversion to take place. As long as she is seroconverted and she's got protective antibodies against HSV1, HSV2, by the time of the baby being delivered, then you can aim for a vaginal delivery. What about third trimester acquisition? I guess Belinda was a third trimester acquisition, but that was very close to delivery. If you acquire or if you get genital herpes in the third trimester, but not at the time of labor, the woman still needs to be treated with acyclovir. You still need to start suppressive therapy after 36 weeks till the time of delivery. Again, here the likelihood of seroconversion might be a little bit low, depending on how many weeks it has been since she was diagnosed with the genital lesions. So if she's not seroconverted, then the risk for transmission to the newborn would still be high, and we would treat her as high risk. Looking at recurrent maternal genital herpes, again, the transmission risk here is low. Would still treat this woman with acyclovir and suppressive therapy from 36 weeks. You would do a speculum examination to see if they have any active lesions at the time of delivery. If there's no lesions, most of these women would progress to vaginal delivery. If they do have active lesions, there is some debate whether you do a cesarean section or vaginal delivery. The RCOG guidelines, I think, say that these women should be offered a vaginal delivery, and you have to weigh the risk of cesarean section for the lady as well, because even though cesarean section in this case might reduce transmission, it's not going to eliminate disease. I don't know what the obstetricians think of that, Peter. Would you? So even if it is recurrent, you would mostly aim for cesarean. I think, yeah, different countries follow a sort of different pattern. So management of the newborn, if they are asymptomatic and they have low risk of infection, while we would do standard neonatal care for these babies, they still need to be observed for signs of herpes disease. And what we would do in these cases would just do swabs at 24 hours to make sure that the PCR is negative. And if the PCR negative, then baby has routine care. Management of a newborn who's symptomatic and has neonatal herpes simplex virus disease, obviously this baby will need complete evaluation, investigation, and treatment with acyclovir. I'll come to neonatal disease in a minute after this. So if you look at neonatal disease, it can present in 3 ways, basically, and there is considerable overlap between these 3 presentations as well. The first is just skin, eye, and mucous membrane disease. The second one is CNS disease, which babies present with meningoencephalitis and signs of CNS infection. And the third one is disseminated disease, which carries both CNS disease and disseminated disease have a very high mortality and morbidity if treatment is not started early. And then you get considerable overlap between these three presentations is as well, which this graph is showing. You can see if you have in red, you have the disseminated disease. So babies with disseminated disease can present with sepsis-like syndrome. They can have pneumonia. They can have CNS infection. They can have conjunctivitis. They can have skin lesions. Probably 60-70% of them will have skin lesions. But again, there's a misconception here. It's not necessary for babies with neonatal herpes simplex disease to have vesicular lesion. So if they don't have cutaneous vesicular lesion, it does not rule out herpes simplex disease. So as you can see, 30% of them will not have vesicular lesions. Or sometimes you might have disseminated disease and the vesicular lesions appear later during the disease. So that's why it's important to just not ignore that diagnosis if you don't have cutaneous lesions. So the skin, eye, mucous membrane infection is seen in 45% of neonatal cases. The common feature in them is a coalescing cluster of vesicles on an erythematous red base. There's a high risk of progression to CNS or disseminated disease if not treated early. So any baby with cutaneous lesions, we would do full evaluation for CNS and disseminated disease as well, and obviously treat with acyclovir. So this is a little baby who's got some blister vesicular lesions on the neck, and you can see this is quite typical of herpes simplex disease. You've got a red erythematous base and vesicular lesions. The next one is a baby who had a scalp electrode put on, and you can see on the presenting part there's a lot of vesicular lesions which are present. That's why it is sort of recommended you should avoid things which cause breach in skin integrity, like putting a fetal electrode on or doing fetal sampling if you have active lesions during delivery. The third one is keratoconjunctivitis, which due to herpes disease, this can be really severe. It is very painful. It presents with a red, teary eye, and it can be vision threatening as well if it is not treated early. The ones with eye involvement will need to have ophthalmologic review as well to make sure that they've not got chorioretinitis as well. So it's easy to recognize, but at times you'll get a vesicular lesion which you might thinking, oh, is this a staph infection? Is this a herpes infection? My rule of thumb is if it crosses your mind, you have to treat it unless you've proven it otherwise. If it crosses your mind that it can be herpes, then we really have to treat it because it is such a nasty disease which progresses so quickly and has such a high mortality and morbidity. CNS infection is seen in 1/3 of the neonatal cases. The spread can be hematogenous or it can be localized through the nerves. Signs of meningoencephalitis and sepsis, these babies will present with sepsis. They might have high fever, they might be hypothermic, they might be lethargic, might have poor feeding, and have temperature instability. Only 60 to 70% will have skin lesions. And if you do CSF, you find mononuclear pleocytosis. There might be moderately low sugars and a mild elevation of protein. The important thing to remember is if you have a strong suspicion of CNS herpes simplex disease, and if you get a CSF which is normal, you probably need to repeat it again because sometimes early on in disease you might not get CNS finding. So it is important you repeat it if you clinically suspecting CNS infection. Disseminated HSV disease, this happens probably in 25% of herpes simplex cases in newborns. Usually sepsis-like presentation, but can have multi-organ involvement. These babies can have hepatitis, can present with acute liver failure. They can have DIC. You're doing blood tests. They have bruising and bleeding from venipuncture sites and can have quite deranged coagulation. They can have pneumonitis, meningoencephalitis. They can present in septic shock, renal failure. These babies usually will end up in intensive care and lead a lot of supportive treatment as well in terms of inotropes, fluids, apart from the acyclovir treatment as well. So it's really important, especially in the community when our baby presents in ED with fever, looking unwell. I think if you're thinking of you're going to do a lumbar puncture to rule out meningitis, and most people would cover for bacterial infection, but you have to keep in mind that there is one virus which you can treat as well. There's not many viral infections you can treat, but this is probably one of the ones which causes meningoencephalitis you can treat. So if you can't get a lumbar puncture, but you've thought of meningitis, you need to cover with acyclovir. So as I said before, high index of suspicion for any baby who has mucocutaneous vesicles, sepsis-like illness, seizures, abnormal CSF, DIC, hepatitis, progressive pneumonitis, which is not getting better with antibacterial treatment, and conjunctivitis, which is typical of HSV disease as well. Diagnosis and treatment. Diagnosis we've already talked about. It involves taking surface swabs or swabs of cutaneous lesions and sending them for PCR, doing a CSF, doing LFTs and CBPs and coagulation. Treatment, empirical treatment wherever there is clinical suspicion or high risk of HSV transmission to the newborn. You would have to start empirical treatment. You can't wait for the result to come and then start treatment. The treatment always will have to be empirical. Dosage 20 milligrams TDS. Duration depends on what disease the baby has. If it is just skin, eye and mucous membrane disease, usually duration of treatment is 14 days. If you have CNS disease or disseminated disease, the treatment usually would be 3 weeks. There is some evidence to suggest that if you have CNS disease, you do a lumbar puncture at the end of 3 weeks. And if the PCR is still positive, then you extend the treatment for a week till you get a negative result. And there's also some evidence to suggest oral suppressive therapy to continue for 6 months. That's known to reduce cutaneous recurrences as well as decrease, as well as improve neurodevelopment outcome in babies who had CNS disease. Again, one more misconception. If you have herpes simplex disease in the acute phase, you can't treat it orally. You have to treat it with IV acyclovir. You can't, even if it is just cutaneous disease, you can't treat it orally. It has to be treated with intravenous acyclovir. Outcome, as you can see, without therapy is quite devastating. In disseminated disease, without therapy, mortality is 85%. And with therapy, it comes down to 30%. So even with early treatment, some of these babies are going to die, but early treatment makes a significant difference in mortality and long-term outcome. Neurodevelopment outcome, if you have normal outcome if in 83% of the cases if you've had early treatment. Central nervous system disease, again, without therapy, 50% mortality, comes down to 5 to 6% if babies have received treatment early. Cutaneous lesions, mortality is less, but without treatment, neurodevelopment outcome can still be poor because a lot of these babies can progress to disseminated disease or CNS disease if they have not been treated early. So that's why it is important to treat the skin cutaneous lesions early as well. In terms of infection control, I guess common sense, contact precautions if you have a neonate with mucocutaneous lesions. Asymptomatic neonates with mothers with active disease, I think it is not quite clear cut what we should be doing. Some people suggest contact precautions till you got negative swabs. A lot of time we get asked a question, if a mother has cold sores or she has herpes labialis, what do you do with then with contact precautions? These mothers, we would suggest, should continue to breastfeed as long as they don't have any lesions on the breast. Do good hand hygiene and try to cover their lesions so that they are not exposed. If staff have herpes labialis or herpes cutaneous lesions, then they should be covered. Obviously, hand hygiene and the policy at children would be not to have direct contact with the patients if you have moist lesions, because the risk of transmission is very high. So that's it. Thank you. Any questions? But take-home message, I guess, from this is remember the misperceptions that if you don't have, you can get neonatal herpes simplex disease even if there is no history in the mother. In fact, majority of those babies don't have a history of mother having genital herpes. And if you are suspecting it, treat it early, whether it's cutaneous lesion or whether there is a sepsis-like syndrome. Thank you.